Bismillahirrahmanirrahim. Assalamu alaikum respected students. I am Dr. Muhammad Ramzan Ansari, Assistant Professor of Pediatrics, and today we are going to discuss long case of bronchial asthma. It is the most common chronic disease of childhood. People perceive that bronchial asthma case will be very easy, but in fact the bronchial asthma case is very difficult as a long case in examination as well as a management case during your clinical practice. It is a chronic inflammatory lung disease characterized by coughing, wheezing, dyspnea, chest tightness, and hallmark is reversibility with bronchodilators. Bronchial asthma is associated with other conditions which is also called asthma triad. Asthma is concomitantly seen in the same patient with allergic rhinitis and atopic dermatitis. So if you get a case of asthma, look for these two conditions as well in your patient. Pathophysiology is little complex. Risk factors are not only environmental but genetics as well. But the type of pattern is not Mendelian pattern of inheritance. So environmental risk factors and genetics risk factors combined lead to bronchial inflammation, which leads to bronchial hyperreactivity, bronchoconstriction, and increased mucus production. This leads to airway narrowing and symptoms of the asthma. Contrary to the beliefs that asthma is only caused by bronchospasm, muscular contraction of the airway, the actual pathophysiology of bronchial asthma consists of bronchoconstriction as well as airway remodeling, airway changes, and increased mucus production. Because of tissue inflammation, inflammatory cells as well as structural cells release mediators like histamines, leukotrienes, prostanoids, platelet activating factors, kinin, adenosine, endothelins, nitric oxide, cytokines, chemokines, growth factors, which all these mediators lead to bronchospasm, plasma exudation, mucus secretion, airway hyperreactivity, and structural changes. And once structural changes have taken place, then the disease becomes slightly irreversible. It is difficult to reverse the structural changes that have occurred in the airways. The symptoms of asthma are due to airflow obstruction resulting from cumulative effect of smooth muscle constriction around airway, airway wall edema, intraluminal mucus accumulation, inflammatory cell infiltration of the submucosa, and basement membrane thickening. This slide compares a normal airway on the left side with with an abnormal airway seen in bronchial asthma patients. During history taking in your long case, it will be very difficult to establish the diagnosis mainstay of because the main way of establishing the diagnosis is clinical. So this questionnaire you need to ask from your patients. A yes answer to any question suggests that an asthma diagnosis is likely. In the past 12 months, have your patient had a sudden severe episode or recurrent episode of coughing, wheezing, chest tightness, or shortness of breath? Have you had colds that go to the chest or take more than 10 days to get over? Have you had coughing, wheezing, or shortness of breath during a particular season or time of the year, especially spring season? Have your patient had coughing, wheezing, or shortness of breath in certain places or when exposed to certain things, for example, animals, cats, dogs, animal dandruff, tobacco smoke, household smoke, or perfumes? Have you used any medications that help you breathe better? How often do you use these medications? Are your symptoms relieved when the medications are used? Based on your clues in the history, you will consider there, because it's a chronic condition which assumes several typical patterns in your your diagnosis, you will consider these things: intermittent attack superimposed upon an asymptomatic baseline, chronic symptoms for a patient who some symptoms punctuated by intermittent worsening, slowly progressive attacks, are morning dipping, which is accentuation of a physiological cycle of pulmonary function in normal individuals, characterized by worsening of symptoms and decreased peak flow in the early morning, with improvement as the day progresses. During examination of your patient, you will have to mention whether your patient is active, alert, and comfortable, or he's anxious and alert. Cyanosed are pink in the air, whether there is tachycardia or tachypnea, pulsus paradoxus, which is fall in systolic blood pressure more than 10 mm of mercury during deep inspiration, bilateral resonant percussion notes or hyperresonant percussion note, which can confuse you towards the diagnosis of pneumothorax. Decreased cardiac dullness is seen in bronchial asthma patient. If there is wheeze, whether the wheeze is expiratory only, a pan-respiratory, or the more severe form of bronchospasm is silent chest. High or low-pitched expiratory bronchi. High-pitched bronchi are easy to detect, but you have to practice your ears to detect low-pitched expiratory bronchi. Increased AP diameter will also be seen in these patients because of air trapping. Peak expiratory flow rate measurements is a very useful tool which is to be taught to the patients and is to be monitored by the clinician as well. How to measure it, how to check it, how to calculate it. First, let's see how to calculate it. You take the height of the patient in centimeters and subtract 100 from it. Then multiply the resulting figure with 5 and add 100. This is your desired peak expiratory flow rate. For example, if a patient has height of 140 centimeter, you subtract 100 from it, remaining 40 is multiplied with 5 and you get 200, you add another 100 to it. So 300 liter per minute is your desired peak expiratory flow rate for your patient. Now you actually measure the peak expiratory flow rate by a peak expiratory flow meter, and if the reading is more than 80% predicted or personal best, then your patient is normal in the green zone. If it is between 50 to 79% predicted or personal best, the patient is in the yellow zone and may need extra couple of puffs of bronchodilator. But if it is less than 50%, the patient is in red zone and needs immediate attention. How to take a peak flow measurement. Purchase a peak flow meter, place marker at 0 or at the lowest number on the meter, stand up, inhale deeply while holding breath, place mouthpiece between teeth with your lips sealed around it, blow out as hard and fast as possible and write down number shown on the meter. And you can repeat this once or twice or thrice, and the best reading out of these will be taken your peak expiratory flow rate for the day. Because asthma has other associations which we have already read, a, a transverse nasal crease due to frequent itching causes a transverse crease. Frequent itching or of the nose causes a transverse crease. This is usually caused by allergic salute, which is actually rubbing the tip of the nose with the palm of the hand. People rub the tip of the nose with the palm of the hand, so they develop a transverse crease on the nose, and this crease denotes that there is allergic rhinitis. Halitosis is bad breath from the mouth due to chronic rhinitis, sinusitis, and mouth breathing due to adenoids or tonsillar enlargement or repeated sore throats, repeated infections of the airway. Look for eczema, atopic dermatitis, nasal polyps. Look for nasal polyps. They are sign of allergic rhinitis as well as they are sign of cystic fibrosis. Now coming over to the differential diagnosis, the examiner next will ask you, what is your differential diagnosis? You have established a diagnosis of asthma on the basis of history, but this could be something else as well. So what are your differential diagnoses? Your differential diagnosis can be bronchiolitis if a smaller child, bronchitis, COPD if an older patient, laryngotracheobronchitis, tracheobronchomalacia, foreign body aspiration, esophageal foreign body, and there can be uncommon conditions which can present as like bronchial asthma, like structural abnormalities. There can be vascular compression or rings around the trachea. There can be eosinophilic esophagitis, which can present in the similar way with airway symptoms and with the upper GI symptoms, and will have bronchospasm as well. Tracheal stenosis and webs, cystic lesions or masses in the airway, tumor, lymphadenopathy, cardiomegaly all can present. Cardiomegaly and cardiac asthma is an identified entity. So you will have to you will have to name all these conditions in the differential diagnosis, and tell your examiner why this is not a bronchiolitis case, why this is not a COPD case, why you don't think that this is laryngotracheobronchitis case. Investigations of bronchial asthma. Chest radiograph will show you hyperinflated lung. If you are able to count 9 ribs posteriorly on the lung fields, then this is a hyperinflated chest X-ray. Because of hyperinflation, the diaphragm will be flattened. There will be horizontal ribs. There will be tear-shaped heart. There will be increased AP diameter on the lateral field peribronchial thickening, which will be seen as ring-like lesions in the hilar area or adjacent to the hilar area. Mucoid impaction with atelectasis at areas. CBC can show anemia, leukocytosis, eosinophilia, and thrombocytosis. RFT, LFT, urinary as baseline will also be performed, but will tell about the other conditions as well. Spirometry is a very important test which is done to demonstrate a reversible airflow obstruction. It differentiates between obstructive lung conditions, restrictive lung conditions, and normal lungs. Airflow limitation is denoted by low force expiratory volume in first second and low force expiratory volume in first second to FVC ratio, which should be less than 0.8, and there should be bronchodilator response improvement in FEV1 more than 12% after use of bronchodilator suggests the diagnosis of obstructive lung disease, that is asthma, COPD, bronchitis. But if patient has normal ratio of FEV1 to FVC, but both are reduced, FEV1 is also reduced and FVC is also reduced, this is a restrictive lung condition. Exercise challenge is another way during spirometry. If there is worsening of FEV1 more than 15% after exercise challenge, this suggests an obstructive airway condition like bronchial asthma. Because children less than 5 years poorly coordinate during spirometry, so a trial of asthma medication may help to establish the diagnosis. Sweat chloride test is done to rule out cystic fibrosis, bronchoscopy, and endobronchial biopsy. In addition to in addition to giving you the diagnostic information, you will be able to take the biopsy. You will be able to take the bronchoalveolar lavage, which will establish further diagnosis whether it is inflammatory or infective, whether the patient has bronchopulmonary aspergillosis or tuberculosis or something like that. Barium swallow will tell you about a tracheoesophageal fistula, if there is an H-shaped fistula, or if there is abnormalities of the esophagus, Barrett esophagus, or if there is eosinophilic esophagitis, or there are other abnormalities of esophagus. And gastroesophageal reflux disease is established, diagnosis is established by esophageal pH monitoring. Serum IgE levels, total serum IgE levels are not a specific test for establishing diagnosis, but more than 2 times or 3 time increase in IgE levels suggest an autoimmune or an allergic condition. Whereas RAST, radio allergosorbent test, is the specific test, is the gold standard test nowadays, although it is expensive and not available everywhere in our country. But this test measures the amount of specific Ig antibodies in the blood which are present if there is a true allergic reaction. Arterial blood gases is done for acute condition to see to diagnose type 1 and type 2 respiratory failure, and sputum examination is also required to know the respiratory colonization of different pathogens. Skin prick test, since after the availability of RAS test is almost obsolete but still is performed in centers where RAS testing is not available. Different allergens are injected into dermis, intradermally injected, and sensitivity is checked. During your history taking, you will have to establish the severity of asthma, whether the patient has intermediate asthma, mild persistent asthma, moderate persistent asthma, or severe persistent asthma. You will have to ask during your history about daytime symptoms and nighttime symptoms. The patient will have intermittent asthma if patient has 2 or less than 2 times per week daytime symptoms and 2 or less than 2 times per month nighttime symptoms. Will have mild persistent asthma if 3 to 6 times per week daytime symptoms and 3 to 4 times per month nighttime symptoms he is having. Will be labeled as moderate persistent asthma if the patient is having daily daytime symptoms are more than 5 times per month night times, 5 or more than 5 times, meaning by once, more than once every in any week. If patient is having nighttime symptoms, then this is moderate persistent asthma. Severe persistent asthma patient will have continuous multiple daytime symptoms and will have frequent nighttime awakening or symptoms. This classification will tell you about the severity of the disease before starting the medications. Once the medication have been started, still you can use the previous classification, but then this classification of control of asthma is more important, whether asthma is controlled, partly controlled, or uncontrolled. For a controlled asthma, patient need to have 2 or less than 2 symptoms per week, daytime symptoms. Less than 2 or less than 2 days per week he's having daytime symptoms. There's no limitation of activity, there's no nocturnal symptoms are awakening, and need of rescue or reliever treatment is again 2 or less than 2 per week. Lung functions are normal and there are no exacerbations in the last 1 year. This is called controlled asthma. Partly controlled asthma, if patient has more than 2 daytime symptoms per week, if there is any limitation of activity, if there is any nocturnal symptom or awakening, if patient needed rescue or reliever treatment more than twice per week, if the lung function, meaning by peak expiratory flow rate, is less than 80% predicted or personal best on any day, and if patient had one or more exacerbation in the last year, the patient will be called partly controlled. And the patient will be called having uncontrolled asthma if there are 3 or more features of partly controlled asthma present in any week, or patient had one episode of exacerbation in this week. Then for 1 week he will be labeled as uncontrolled asthma, and for the remaining time period he will be labeled as uncontrolled. For the management of asthma, the clinicians need to develop patient doctor partnership. Because asthma is a difficult disease with to manage a lot of taboos. Patients perceive that inhalers or metered dose inhalers are not good, nebulizations are good. Well, we will have to educate them that inhalers are much better, spacer use, how to use spacers, why spacer to be used, why powdered inhaler to be used, how frequent to be used, and each and everything is to be educated, because community thinking is 180 degrees away from the reality. They believe use of nebulizations is better as compared to metadose inhaler. Patients believe that mm, systemic medicines like syrups and tablets, bronchodilators in the form of syrups and tablets are more effective, and they are better and as compared to metadose inhaler. All these are social taboos. They believe that steroid injectables are more effective than tablets or oral steroids, whereas the facts are contrary. Oral steroids are more effective as in exacerbations of asthma and in asthma, especially as compared to systemic IV or intramuscular steroids. One has to identify and reduce exposure to risk factor. There are two types of medications: reliever medications and controller medications. Reliever are also called rescue medications. Short acting oral beta 2 agonist, systemic steroids, anticholinergics, and theophylline are all reliever medicines. Controller medications are inhaled glucocorticosteroids, leukotriene modifiers, long-acting inhaled beta-2 agonist, systemic glucocorticosteroids, theophylline, and anti-IgE. Different preparations are available in the market for the long case viva and for TOACS. One need to know these reliever names, whether what is metadose inhalers, what is dry powder inhalers, what is rotahaler, what is discus inhaler, the different combinations of relievers, controllers. You need to know all these things to sail through your viva. These are steps of therapy. If patient is well controlled for 3 months, you can step down one level. But if patient is partly controlled or uncontrolled, then one has to step up immediately. Step 1 is inhaled short-acting beta-2 agonist. Step 2 is add inhaled steroid 200 to 800 microgram per day. Start at dose appropriate for severity of the disease. Step 3 is add inhaled LABA. Assess control of asthma. If good response to LABA, continue LABA. Benefit from LABA but inadequate control, continue LABA but increase dose of inhaled steroids. No response to LABA, stop LABA and increase inhaled steroid to 800 microgram per day. If still inadequate, consider other therapies. Why step 3 is more elaborate? Because most of the patient will be needing step 3 therapy. So step 3 is very important. In step 4, consider trial of increasing inhaled steroid up to 200 microgram per day. Addition of fourth drug, that is leukotriene receptor antagonist or theophylline, can be considered. Here another mistake in the local community practices is that leukotriene receptor antagonist is started even before inhaled SABA or LABA. This is a very wrong practice, and initially inhalers, metadose inhaler must be started, and later on leukotriene receptor antagonist should be started. In step 5, in step 5, we use daily steroid tablets and maintain high dose inhaled steroids, and anti-IgE treatment can be considered, which are biological agents and very expensive. How to step down? When controlled on medium to high dose inhaled glucocorticosteroids, 50% dose reduction at 3 months interval. When controlled on low dose inhaled glucocorticosteroids, switch to once daily dosing for 3 months and then stop them. When controlled on combination inhaled glucocorticosteroids and long-acting inhaled beta-2 agonist, reduce dose of inhaled glucocorticosteroids by 50% while continuing the long-acting beta-2 agonist. If control is maintained, reduce to low dose inhaled glucocorticosteroids and stop long-acting beta-2 agonist. Stepping up treatment in response to loss of control at any time. Step up is possible anytime, but step down is not possible before 3 months. Acute exacerbation of bronchial asthma, also called acute severe asthma these days. There are two types of exacerbations or status asthmaticus: acute severe episode or life-threatening episode. Now, first let us define what is acute exacerbation of asthma or what is status asthmaticus. When patient excuse me, when patient fails to respond to usual inhaled therapy, then the episode is labeled as status asthmaticus or acute severe asthma. In acute severe attack, patient can't complete sentences in one breath, are too breathless to talk or breathe. There will be tachycardia, there will be tachypnea, there will be respiratory distress. Patient might be cyanosed or may have to make strenuous effort to remain pink in the room air. But in life-threatening asthma, the patient will have silent chest. There will be cyanosis, there will be poor respiratory effort, there will be hypotension, there will be exhaustion, and there will be confusion and coma. Prognosis is usually asked in the Viva. If there is family history, these all are bad prognostic signs. Family history of atopic, coexistence of atopic disease, bronchiolitis in infancy, parental smoking, low birth weight, prematurity, ex-premi or long stay on oxygen in the neonatal period, or bronchopulmonary dysplasia, age at presentation. If earlier age, then prognosis is poor. If increased severity and increased frequency of episodes, it is bad prognostic sign. And lung function measurements. This is all for today's lecture. Thank you very much, students, for patient listening.